Now,
Yes, sir. Now it is visible.
it is visible. Okay. So we'll discuss. We are going to discuss about the integrity of ligaments, and we do we assess the integrity of ligament by the valgus stress test for the medial collateral ligaments. See, medially there are collateral ligaments. It connects this ligament connects the medial aspect of the tibia and the femur. And if there is any injury over the ligament, we do a stress test, and the valgus stress test we do for the to test the integrity of the medial collateral ligament. And see here, the examiner has put one hand over the lateral aspect of the thigh, lower end of the lateral aspect of the thigh, just close to the knee joint, and with the other hand he provides the valgus stress, and because of this maneuver, there is a little bit opening over this medial tibio area happens, and it causes a stress over this area. And if patient feel pain opening over this area, this indicates the medial collateral ligament injury. And again, reverse is also known as the valgus test for the lateral collateral ligament. That is known as the varus test for the lateral collateral ligament integrity. If the position of patient is lying and leg is lifted and knee is kept in 20-30 flexion, gentle adduction force to test the lateral collateral ligament and abduction force to test the medial collateral ligaments. Force is applied, and one is trying to force open the joint. Finger over the joint line can appreciate opening up of the joint. Even the joint doesn't open, but there is pain. It indicates there is the like ligamentous injury. Second test is known as test for ACL, intercruciate ligament test. This is known as anterior drawer test. See here in this diagram, the patient is in crook-lying position. Knee in this position, now therapist has sit on the foot of the patient, and he has grasped the upper part of the tibia with both hands, and he is trying to pulling it up. This is for the anterior. This is the anterior for the integrity of the intercruciate ligament, and this test is known as anterior drawer test. Patient is lying supine, knees 90-degree flex with the foot flat on the couch. The examiner sits rightly on the foot to stabilize, and the upper end of the tibia is held between the two hands in such a way that fingers are behind the knee. A gentle pull is applied on the upper end of the tibia, and forward movement of the tibia in relation to the femoral condyle appreciated, and it, if anything, like up to half centimeter is basically normal. If more than half centimeter displacement is there, it indicates there is ACL injury, intercruciate ligament injury. Hello. This is not a drawer test. And this test is also do with some modification, that is known as Lasik test. And for the posterior cruciate ligament integrity, the ligament is injured uncommonly. And this test is basically do in the same way like in radar test, but here the like therapist has to apply uh, pulling force in backward direction. That means therapist has to apply pushing force, not pulling, pushing force in backward direction. And again, if displacement of the like tibia with respect to femur happens more than half centimeter, it indicates the posterior cruciate ligament injury. This is known as posterior drawer test. So these are the two tests basically we do to evaluate the integrity of the ligament. One is a stress test for the medial collateral ligament injury, and second is drawer test, anterior drawer test for ACL injury, and posterior drawer test for the PCL injury. In case of seminal cartilage injury, that is seminal cartilage also known as meniscus, or to test the meniscus to evaluate whether any kind of injury is there or not. We basically do two type of tests. One is known as McMurray test, other is known as Applet grinding test. You can do any test. Applet grinding test it's a bit easier. Patient has to lie in prone position on the couch. Therapist has to place one hand on the back of the thigh and with the other hand flex the knee with the other hand flexes the knee, which is already 90 degree flex. Therapist has to now apply compression force along the long axis of the tibia while rotating it on the femur. Pain during the movement indicates a meniscal tear. Pain on lateral rotation. Pain on lateral rotation indicates the medial meniscus tear, and while for the medial rotation, it indicates lateral meniscus tear. This is known as Applet grinding test. It's a very simple test. The patient has to lie in prone position and he has to flex the knee at the 90 degree flex position. When therapist has to put one hand over the back of the thigh and with the other hand he has to place other hand on the foot and he has to apply compressive force along the long axis of the tibia and rotate. He has to rotate the leg on the femur, and if pain will arise in the medial rotation position maneuver, it indicates the injury of the medial meniscus, and if pain will be arise by rotating the leg on the femur in medial rotation direction, it indicates tear of the lateral meniscus. This is known as Applet grinding test, and we do this test for the confirmation of the diagnosis of medial meniscus meniscus injury. and इसी का थोड़ा सा सब्स्टिट्यूट है, दूसरा टेस्ट है, दैट इज नॉन एज मैकमुरे टेस्ट. See, McMurray test में क्या करते हैं? This is the position patient has to lie in supine position, and patient has to flex the hip and knee. Therapist will put one hand over the lower end of the femur and with on the another hand on the lower end of the leg, and he has to apply the stress, force, and rotation also. While the patient lying on the couch, the therapist stand at the side of the injured limb. He or she grasps the foot firmly with one hand and the knee with the other hand. The knee joint is completely flexed, the foot is rotated externally, and the leg is abducted. Foot को externally rotate करना होता है, leg को abduct करना होता है, and in this position, the joint is now slowly extended, keeping the leg externally rotated and abducted. As the torn cartilage get caught during the maneuver, the patient will experience pain and click sound. It may hurt. The angle at which these symptoms occur indicates the position of the tear. The more posterior the tear, the more flexed position of the knee is when the sign becomes positive. A similar test with the foot initially rotated and leg abducted for the lateral meniscus tear. So these are the two tests we can do to test the injury of the meniscus over the knee joint. McMurray test. Then, after assessing these things, we can this joint, we can go for the assessment of the hip joint assessment. Hip joint assessment, we can do, we can like assess the posture and gait. Lots of abnormal gait abnormal gait patterns are there. You can tell patient to go for walk for few seconds or few steps, and you can assess whether there is any abnormal gait is present or not. See, these are the abnormal gaits. I think you all know very much aware about all these abnormal gaits: entalgic gaits, canberra gait, short limb gait, circumduction gait, flexion deformity. So these are the gaits, abnormal gait we should know while assessing the hip joint or the, you can say, pelvis. Entalgic gait, it is also known as painful hip gait. इसमें क्या होता है? The patient can hardly bear weight on the affected side, so he quickly takes the weight of the affected limb to the normal limb. Hence, he keeps the affected limb on the ground for a very shorter time than the normal side. This type of gait pattern is known as entalgic gait. इस तरह के हम देख सकते हैं किसी एक साइड hip joint pathology है तो patient on that side bears weight very small duration of time, and he just shift the weight from the affected side to the normal side. This is known as entalgic gait. Second is Trendelenburg gait. Trendelenburg gait में क्या होता है? This is again indicate the hip joint pathology, and to test the abductors. तो इस Trendelenburg gait में क्या होता है? Patient stands on the normal limb, the opposite AS/IS goes up. अगर पेशेंट जो है नॉर्मल साइड से वेट बेयर करके वो खड़ा होगा तो क्या होगा? The opposite side AS/IS goes up. The patient stand on the affected side, the opposite side AS/IS drop. This indicates weakness of the abductors of the hip. Abductors कौन कौन से मसल्स होते हैं? Can you tell anyone? How many abductor muscles are there?
Hello.
कौन कौन से abductor muscles होते हैं हिप जॉइंट में? बता सकते हो आप लोग?
Hello. Am I audible?
Yes. Abductor muscles कौन कौन से होते हैं?
सर ग्लूटियाई का ग्रुप जो बेसिकली होता है ग्लूटियस मैक्सिमस, ग्लूटियस मीडियस, ग्लूटियस मिनिमस.
ग्लूटियाई में सारे मसल्स abductors नहीं होते. Gluteus maximus is the
सर TFL, gluteus medius and maximus and TFL.
No, gluteus maximus is hip extensors. Gluteus maximus is the prime hip extensor. Gluteus medius is the prime hip abductor. Medius क्या होता है? Hip abductors होते हैं, ठीक है? और उसके साथ साथ और दूसरे मसल्स भी हैं, जैसे TFL आपने कहा, TFL sartorius के में भी कुछ, इसका भी कुछ like you can say these are accessory muscles, but the prime muscle is gluteus medius.
Okay, sir.
Gluteus maximus is the extensor. Prime extensor. Yes. So this test is only we do for the assessment of the gluteus medius. ठीक है? Gluteus medius की weakness है, तो इस तरह का you can say finding Siley. This is known as Tenderberg test, Tenderberg gate. Is it okay? Clear?
Yes, sir.
Now we can go for the short limb gait. If the affected limb has become short due to some disease, when the patient walks, the whole affected side of the body dips down in order to make it possible for the patient to bring the foot to the ground. It is the up and down movement of the half of the body which is characteristic of the short limb gait as against the sideway lurching seen in the tender gait. उसी तरह इसमें भी गेट होता है बट इसमें थोड़ा सा डिफरेंट होता है. उसमें क्या होता है कि ASIS जो है वो अपोजिट साइड में क्या होती है, अप हो जाती है. शॉर्ट लिम तो आप ऐसे भी एसेस कर सकते हो लिम लेंथ डिस्क्रिपेंसी के थ्रू. यू कैन मेजर द लिम लेंथ डिस्क्रिपेंसी. ASIS मीडियम मेलियोसिस की बीच का लेंथ आप मेजर कर सकते हो दोनों लिम का. यू कैन से कैन फाइंड आउट द लिम लेंथ डिस्क्रिपेंसी. सेकेंड नेक्स्ट गेट इज circumduction gait. Circumduction gait में क्या होता है, when the hip is flexed in abduction occurs apparently the lengthening of the limb. When the hip is flexed in abduction, this occurs apparent lengthening of the limb. In order to walk in such a situation, patient has to take the affected long limb in a round about fashion and thus take the step forward. Basically circumductory gait जो है इसमें क्या होता है कि फ्लेक्स पेशेंट जो है फ्लेक्स नहीं कर पाता है. क्या होता है, पेशेंट जो है और ग्राउंड क्लियरेंस के लिए क्या करता है, वो फ्लेक्सर्स की वीकनेस के चलते वो क्या करता है, एब्डक्टर्स का हेल्प लेता है और एब्डक्ट करके और स्लाइटली फ्लेक्स करके फिर वो आगे स्टेप लाता है, हील स्ट्राइक करता है. और बेसिकली दिस टाइप ऑफ गेट फेनोमेना ऑकर्स इन केस ऑफ द हेमीप्लेजिया. तो दिस इज नोन एज सर्कमडक्शन गेट. ग्राउंड क्लियरेंस के लिए पेशेंट हिप को फ्लेक्स करता है और एब्डक्ट कर देता है और दो so that the heel doesn't drag on the foot doesn't drag on the ground. This is known as circumduction gait. Flexion deformity you can also check. It is very easy to check. Because if there is flexion of the hip deformity occurs, there is compensatory lumbar lordosis happens, and this can be assessed with the test. So this is the test. If a patient is having flexion deformity, you can tell patient to lie in supine position with knee straight and hip straight. What will happen? The flexion is less for the compensation of the. So flexion is less, extension of hip is less, and because the flexion deformity, hip in flex position, extension is not there. So what patient will do? He will compensatory increase the lordosis, and this phenomena occurs in case of the hip flexion deformity. You can test the hip flexion deformity in this way. फिर ASIs का टेस्ट भी आप कर सकते हो. The ASIs of both sides should be exposed. The patient is asked to stand on the normal leg. As he does so, the opposite ASIs will be lifted off. That is, the pelvis will be tilted toward the side bearing weight. Tenderberg sign का test है. We have already discussed. थॉमस टेस्ट में वही होता है for the to test the flexion deformity of the hip. limb length measurement, because in case of the poliomyelitis or sometimes in case of the femur fracture, there is a chance of the limb length discrepancy. And if limb length discrepancy occurs, what happens because of this? Shift is way towards the other side, and it may cause the scoliosis. And this thing basically happens in case of the poliomyelitis. And for the compensation of the discrepancy, we recommend the insole to increase the height of the sole of the shoes, so that the both limbs should come in same position, in the same length. So then the both ASIS will be come in the same line. For the measurement of true length, what we do, we put measuring tape over the ASIS to the, and the other end of the tape over the medial malleolus, and we measure the length of the both limb. If any discrepancy is there, we should note it, and this discrepancy is known as length discrepancy, limb length discrepancy. These are the biomechanical aspect of different bony prominence. You can say any deformity in the pelvis and the hip joint. For the elbow joint assessment, we do some special tests for the to test lateral epicondylitis, because in some patients complain there is pain over the lateral aspect of the elbow over the common extensor origin. This condition is known as tennis elbow. And for the assessment of the tennis elbow, we do some special tests. First is known as ringing test. When the patient is asked to ring a towel, pain is felt at the lateral epicondyle in case of tennis elbow. We also do Kujan test. Kujan test में क्या होता है? With a forearm pointed position, ask the patient to make a tight fist. The examiner now hold the fist and palmar flex the wrist, means flex the wrist downwardly. Pain will be felt at the lateral epicondyle in case of tennis elbow. This is known as Kujan test. ये बहुत सिंपल टेस्ट है. बस forearm should be in quadrant position. Patient has to make tight fist. Examiner will hold the fist and again flex the wrist, and then he will alternately deviate the wrist. In this maneuver, what will happen? A stretch will appear over the origin of the common extensors of the wrist, that is over the lateral condyle. And this condition is known as you see pain will be felt by the patient over the lateral condyle area. We can say patient is having tennis elbow. And tennis elbow Lots of causes are behind the tennis elbow. Tennis elbow occurs because of the, you can say, repeated wrist movements, flexion extension movements. It's not only happens in the tennis player, but it also happens in case of the badminton players, in you can say cricket player. Also, ladies, housewives, those are working house making food and or the and like moving the wrist and forearm in different position. Again, uh, washing the clothes. Even teachers, those are working, those are teaching on the blackboard and like moving his hand on the blackboard for writing and like removing the writing with the duster. In this, there is a chance of micro tear over the common origin of the wrist extensors or the lateral epicular area, and this may cause the tennis elbow. Shoulder joint examination we already covered.
Yes, sir.
Now, examination of the patient with old fracture. Fracture may be united, may be malunited, may be non-united. United में क्या होता है? There is no mobility, no pain on a stress, or no deformity or shortening. See, we can assess these things, diagnose these things with the help of the X-ray. But without X-ray, we can also evaluate whether the fracture has been like united or not. Because क्या होता है कि in 1 month there is formation of callus bridge between two fracture fragments. Or complete healing में it takes time. But after 1 week, we start the active movements of the limb because one callus bridge has been formed. And in case of the malunited, what you will see no mobility, no pain on the stress, but deformity and shortening is there. You can suspect for the malignant. Or on united case, abnormal mobility with or without pain at the fracture site. If there is mobility without pain, it is called the pseudoarthrosis. In some cases, there may be no appreciable abnormal mobility, but only pain on a stress the fracture site. We can confirm the diagnosis with the help of the X-ray. Examination of the patient with old fracture, we can see deformity, shortening, swelling, wasting. A scar we can also see. Palpate, we can do palpation also, temperature, tenderness. If tenderness is there, you can suspect or the you can suspect that fracture has not been united. Palpation of bone ends, abnormal mobility, absence of transmitter moment. You can measure the limb length and limb girth. Because if the fracture has not been united, patient there will be pain and patient will not use the limb. What will happen? There will be the disuse atrophy. And disuse atrophy causes decrease in the girth of the muscles, and you can see the muscle wasting. Random movement will also be affected. बोनी लीजन की कैसे आप एग्जामिनेशन कर सकते हैं? Following are the common presenting complaints of the patient presenting with bony lesion, means bone में कोई tumor है. Now examination of a spine. See the normal spinal movement you can see while testing the flexion of the spine. If patient will bend forward, what will happen? Normally there should be movement between two adjacent spinous process. It indicates the back extensor muscles are in good conditions. If there is shortening in the back extensor muscle, what will happen? Patient will not able to flex the spine properly and he will do more movement over the hip. You can also observe the gait while examining the spine. Observe the gait as the patient walk on the into the room. A side lurching gait may suggest scoliosis. Patient with painful condition of the spine walks rather cautiously, with short step and a steep spine. Deformity in the spine, in the neck, there may be the forward head posture, and it can increase the lordosis curve over the neck. And in case of the dorsal spine, thoracic spine, what will happen? We can see the kyphotic forward bending of the body. It indicates the kyphosis, and over the lumbar area you can see lumbar lordosis. More you can say patient is more curve is there on the lumbar aspect. And again, if there is lateral deviation, you can say it is scoliosis. A diffuse kyphosis occurs in case of ankylosing spondylosis, Sherman's disease, osteoporosis. इसमें क्या होता है? काइफोसिस के साथ साथ क्या होता है? डिफ्यूज काइफोसिस होती है न्यूरोलॉजिकल टेस्टिंग के लिए क्या क्या करते हैं हम स्पाइन में? एसएलआर टेस्ट करते हैं. एसएलआर टेस्ट में क्या करते हैं? There are SLR tests. Patient has to lie in supine position. His affected leg is lifted gradually with the knee straight. As this is done, the patient complains of pain or stretching on the back of thigh or in the calf. The angle at which it occurs is noted. A positive SLR test at 40 degree or less is suggestive of root compression. The leg is now lowered a little, tilt, the stress become less. At this angle, if the ankle is passively dorsiflex, the pain at the back of the thigh or the calf again be felt. This is called reinforcement positive sign. तो एसएलआर में बेसिकली टेस्ट क्या होता है? सुपाइन लाइन पोजीशन में पेशेंट को आप करते हो एंड एग्जामिनर हैज टू लिफ्ट द leg in knee straight position, and it occurs around 40 degree 45 degree तो 60 डिग्री तक भी माना जाता है एसएलआर पॉजिटिव। उसके बियॉन्ड में क्या होता है? यू कैन सस्पेक्ट अबाउट द एसआई जॉइंट डिसफंक्शन। तो एसएलआर टेस्ट बेसिकली किसको इंडिकेट करता है? देयर इज कंप्रेशन ऑफ द sciatic nerve. Sometimes क्या होता है कि there is compression of sciatic nerve because of the tightness of the piriformis muscle. It is known as piriformis syndrome. Patient those are putting like wallet on the back pocket and they sit on the chair and do work, sitting work for long duration of time. Even they do biking or even driving. In that case, there is a chance of the tightness of the piriformis muscles, and you can, if you know the course of the sciatic nerve basically passes through the passes in between the piriformis muscles, and if there is tightness occurs in the piriformis muscles, there is a chance of the compression of sciatic nerve. उस केस में क्या होता है कि एसएलआर टेस्ट आपका पॉजिटिव नहीं आएगा, बट फिर भी बिकॉज ऑफ द piriformis tightness, patient may complain sciatica type of symptom that is known as piriformis syndrome. Second test is Lasik test. इसमें क्या करते हैं? This is the modification of SLR test, where first hip is lifted to 90 degree with the knee bent. Then the knee is then gradually extended by the examiner. If nerve stretch is present, it will not be possible to do so, and the patient will experience pain in the back of the thigh or the leg. This is known as Lasik test. मोटर पावर कैसे टेस्ट करते हैं? These are examined in different muscles group for the limb, especially the EHL. EHL का फंक्शन क्या होता है? Extension analysis long as it extends the great toe, and it also helps in the dorsiflexion of the ankle. EHL के पार्ट को टेस्ट करते हैं, dorsiflexus के पार्ट को टेस्ट करते हैं, डोमेटोम को एग्जामिन करते हैं फॉर इन्फॉर्मेशन, रिफ्लेक्सेस टेस्ट रिफ्लेक्सेस, डीप टेंडर डीटी एडिफरल रिफ्लेक्सेस, वो किसी रिफ्लेक्सेस में वेबेंस की साइन ये सब टेस्ट करते हैं. These are the neurological tests we do for the any type of compression of the like the spine or और एसआई जॉइंट एग्जामिनेशन. एसआई जॉइंट एग्जामिनेशन के लिए क्या करेंगे? एसआई जॉइंट बेसिकली पेशेंट को फोन लाइन में आप लेटाने के बाद आप देखोगे कि जो दो जस्ट ग्लूटियाई के ऊपर आप ग्लूटियाई के ऊपर आप दो डिंपल देखते हो दोनों साइड पे. दैट डिंपल इज नोन एज पीएसआई, इसको बोलते हैं पोस्टीरियर सुपीरियर स्पाइन एरिया. We when we put your thumb and press like put pressure over that area, that dimple area, patient will complain pain, tenderness. You can suspect for the SI joint involvement. SI joint involvement में और भी करते हैं, उसमें पम्प हैंडल टेस्ट भी करते हैं, पेशेंट को स्पाइन लाइन लेटा करके टू लाइन पोजीशन में नी को अपोजिट चेस्ट की तरफ पुश करते हैं, नी हिप फ्लेक्स करके, तो पेशेंट कंप्लेन पेन ओवर दैट एरिया, उसको बोलते हैं पम्प हैंडलिंग टेस्ट. तो these are the tests we also do for the SI joint dysfunction. और बेसिकली तब होता है जब पेशेंट, some patients has like faulty posture, they adopt while sitting. कई बार क्या होता है, लोग एक ही बटक पे वेट देकर बैठते हैं एक ही साइड से, तो क्या होता है SI joint डिसफंक्शन हो जाता है और पेन क्रिएट होता है. तो उसको दो तरीके से ठीक किया जा सकता है. वन इज द पोस्चर करेक्शन, अदर इज द स्ट्रेंथनिंग ऑफ द पेल्विस एंड हिप मसल्स. पेल्विस हिप मसल्स को स्ट्रेंथनिंग करोगे अच्छे से तो SI जॉइंट प्रॉब्लम ठीक हो जाती है. एंड ऑल्सो यू शुड फोकस ऑन द स्ट्रेंथनिंग ऑफ द क्वाड्रेटस लंबोरम मसल्स, जो साइड फ्लेक्शन करती है स्पाइन की. दीज आर द मसल्स रिस्पांसिबल फॉर द stability of the SI joint. SI joint का stability के लिए hip joint muscles, pelvic muscles responsible होते हैं. इसके strengthening plus posture correction is required. This is SLR test and this is the Lasik test. सर्वाइकल स्पाइन में सर्वाइकल स्पॉन्डिलाइटिस के लिए स्पर्लिंग टेस्ट करते हैं. उसमें क्या करते हैं, कंप्रेशन और डिस्ट्रैक्शन टेस्ट होता है. पेशेंट इज इन सिटिंग पोजीशन. व्हाट एग्जामिनर डू, एग्जामिनर if patient is complaining pain over the over neck area, back of the neck area, and also towards one side of the neck trapezius area, and again the arm, and also over the forearm, the tingling sensation over there. So what we do is we tell patient to sit in the on the chair. The examiner stands beside of the patient, and he tell patient to bend the neck slightly towards the affected side of the pain, and also rotate slightly and apply compression pressure. What will happen? The like tingling sensation will be aggravated. This is the sign of the cervical spondylitis. और उसके रिवर्स में क्या करते हैं, डिस्ट्रैक्शन देते हैं. कंप्रेशन होगा, डिस्ट्रैक्शन में क्या होता है, दिस सिम्टम्स बेसिकली रिलीव्ड. तो दिस इज नोन एज कंप्रेशन एंड डिस्ट्रैक्शन टेस्ट फॉर द इवैल्यूएशन ऑफ द cervical spondylitis. यही सारे बेसिक टेस्ट हैं. And I think you all people already may be aware about all these tests, because we have studied all these things in your graduate level and postgraduate level syllabus.
Yes,
Once
sir.
you are going to do like research in PhD, the evaluation part is also important. And apart from this, you should also be aware about the research methodology, how to do research, what are the methods we should follow in doing research. Differential diagnosis you should know.
Yes, sir. Knowing all these tests will really help us in creating the differential diagnosis and precising the methodology more of.
Exactly. Because see, when you are going to a study on a certain case, certain condition, so it's firstly you will have to assess the case, and then you will, if patient is like fulfilling the inclusion criteria, then you will offer patient to participate in your study. So that is why evaluation has its important role in research area. And for this thing, you can go through the Maggie physical orthopedic assessment book. It is very good book.
Yes.
Hand to knee gait, basically this type of gait happens in case of the quadriceps weakness. Quadriceps weakness. Patient is not able to extend the knee. This type of gait occurs in polio patient. You might be knowing the seizure gait occurs in the spasticity over the adductor compartment of the thigh. Because of the adductor compartment spasticity, the patient child cross the leg. This is known as seizure gait, when it occurs in case of cerebral palsy. Foot drop gait is also known as high stepage gait. इसमें क्या करना पड़ता है, ग्राउंड क्लियरेंस नहीं हो पाती है, डॉर्सिफ्लेक्सर्स काम नहीं करते हैं, बिकॉज ऑफ वीकनेस ऑफ डॉर्सिफ्लेक्सर्स पेशेंट flex the knee and hip for the ground clearance while walking. This is known as high stepage gait. You should also know how to assess the gait, normal gait, heel strike, mid stance, heel up, then toe up, then swing position, then heel strike. RL gait cycle you should know. Again, how many muscles works during the stance phases and swing phase, and at which sub phases position, and which muscles basically participate to perform a certain function. You should know about the particular, some conditions, some disease occurs at the particular age group patients. It's polio, 1 to 2 years. People are at this age, children are more prone to this disease. Rickets, it's basically nutritional disease, occurs due to deficiency of the vitamin D, calcium deficiency in children. It occurs again at this 1 to 2 years of age group. Pertussis disease 5 to 10 years age group. Sleep capital epiphysis 12 to 16 years. Acute osteomyelitis or arthritis. Osteomyelitis less than 15 years. Bone malignancy 10 to 20 years. PIBD 20 to 40 years. At this age, people are young but they do more and more work. इसी एज ग्रुप में जो है this 20 से 40 years ये जो यंग एज ग्रुप माना जाता है, मिडिल यंग एज ग्रुप, इस ग्रुप के लोग जो है इस टाइम पे इस पीरियड में बहुत स्ट्रगल करते हैं अपने हर फील्ड में, स्टडी कैन से फिजिकली भी, एंड एट दिस केस दिस स्टेज देयर इज अ चांस ऑफ PIBD. Because weight pulling, waist pushing, you can say this thing basically mechanical problem होती है PIBD because of the biomechanical dearrangement of the spine. It causes PIBD. Rheumatoid arthritis 20 to 40 years age group को होती है. कुछ डिजीज ऐसे होते हैं जो पार्टिकुलर जेंडर ग्रुप को होते हैं, जैसे CDH फीमेल में ज़्यादा पाई जाती है, स्लिप इपिफाइसिस मेल्स में, रूमेटॉइड आर्थराइटिस फीमेल्स में, एंकाइलोजिंग स्पॉन्डिलाइटिस फीमेल में ज़्यादा होती है ओस्टियोमालेशिया फीमेल में, ऐसा देखा गया है। इट्स बेसिकली ऐसा ऑब्जर्वेशन है, रिव्यू लिटरेचर से पाया गया कि सम डिजीज हैज कोरिलेशन विद द जेंडर। तो आप लोगों ने क्या कुछ टॉपिक सिलेक्ट करना शुरू किया है, क्या किस पे स्टडी करोगे आप लोग? कोई केस, इंटरेस्टिंग केस, कोई आपका इंटरेस्टिंग कोई टेक्निक इस पे मास्टरी हो, वैसे ऐसा
सर
सिलेक्ट किया है? अभी कुछ
सर
सोचा नहीं?
मेरा स्पेशलाइजेशन मास्टर्स जो कार्डियोपल्मोनरी था, और मैं पिछले 8-10 सालों से काम कर रही हूँ, और मुझे अभी यहाँ पे ज्वाइन करने से पहले मैंने मेनली आईपीडी ही सारा देखा है।
हम्म।
तो मेरा प्राइमरी डोमेन तो सर कुछ आईपीडी पॉपुलेशन या हेल्दी पॉपुलेशन पे लेके कुछ, या तो एक्सरसाइज टेस्टिंग पे करूंगी, जो 2 मेन एरियाज में सर्च कर रही हूँ अभी, एक एक्सरसाइज टेस्टिंग को एक्सप्लोर कर रही हूँ, और
ओके।
या फिर कुछ इंटरवेंशन में भी पोस्ट टीबी सीक्वले जो होते हैं उन पे।
पोस्ट टीबी ट्यूबरकुलोसिस, ओके। हम्म।
तो पोस्ट टीबी सीक्वले जो होते हैं उनका लंग फंक्शन बहुत डिटोरिएटेड होता है, तो
हम्म।
एक वो एरिया एक्सप्लोर कर रही हूँ, अगर वो पॉपुलेशन अच्छी मिल जाती है मुझे तो वो। अदरवाइज पल्मोनरी पैथोलॉजीज में अभी बहुत सारा एक्सरसाइज टेस्टिंग में, स्पेशली सब मैक्सिमल टेस्टिंग में काम नहीं हुआ है ज्यादा।
ओके।
तो मेरा मास्टर्स का डिसर्टेशन भी प्राइमरीली एक इक्वेशन मैंने डेवलप की थी मास्टर्स में, नॉर्मल पॉपुलेशन पे
ओके।
सब मैक्सिमल टेस्टिंग के लिए, तो मैं भी उसमें आगे अभी दोनों एरियाज को सर्च कर रही हूँ, जिसमें ज्यादा बेटर स्कोप दिखेगा वो जाऊंगी।
तो सी आपको दो तीन चीजें देखनी होती है। फर्स्ट तो कौन सी प्रॉब्लम आप जहाँ भी जिस सेटअप में काम करते हो, जिस ओपीडी में, हॉस्पिटल में, जिस कॉलेज में आपका जहाँ ओपीडी है, तो किस टाइप के केसेस ज्यादा आते हैं, तो मींस अवेलेबिलिटी ऑफ द केसेस, वो आपको देखना
यस
होगा
सर।
कि आपके लिए कौन
हाँ
से
जी।
केस अवेलेबल है। सेकेंडली टेक्निक, आप किस पे, आप इंटरेस्ट क्या है, किस टेक्निक पे आपने मास्टरी है, आपकी आपका इंटरेस्ट है, आपने काम किया, आपका कॉन्फिडेंस है। एंड थर्डली जो आप बता रहे नॉर्मल पॉपुलेशन को करना है, तो आप कर ही सकते हो। नॉर्मल पॉपुलेशन में अगर आपको कुछ फाइंड आउट, कुछ न्यू चीज फाइंड आउट करनी है, एंथ्रोपोलॉजिकल एंथ्रोपोमेट्रिक डाटा लेना है, या फिर और भी कुछ वाइटल टेस्ट वगैरह जो करते हैं, जैसे पीक एक्सपेक्टिव फ्लो रेट हो गया, VO2 मैक्स हो गया, इस तरह की चीजें जैसे आप कार्डियो में बता रहे हो, तो
जी
you can
सर।
test on the normal population also. Depending upon the availability of the cases, your interest, your mastery, सब चीजें, एंड अगेन आपके गाइड जो है वो भी गाइड करेंगे, उनका भी रोल है। तो गाइड
हाँ
डिस्ट्रीब्यूशन
जी
भी
सर।
नहीं हुआ ना, हुआ है क्या
सर
गाइड?
गाइड डिस्ट्रीब्यूशन तो यहाँ पे सर दिग्विजय सर ही हैं जो गाइड होंगे हम
अभी
दोनों के।
हाँ, तो वो तो गाइड करेंगे, क्योंकि मेरे यहाँ भी है, मेरे अंडर में भी लोग जितने PhD स्कॉलर हैं, कईयों को मैं गाइड कराऊँ, जब जिस ऑर्थो के भी हैं, न्यूरो के भी, कार्डियो के भी हैं। तो
जी
PhD
सर।
में बेसिकली टॉपिक बेस्ड स्टडी होती है, ठीक है, इसमें स्पेसिफिसिटी पे ज्यादा ध्यान नहीं दिया जाता है। अगर आपका इंटरेस्ट कितना है, रिसर्च कौन सा टॉपिक पर करना चाह रहे हो, तो मैं
हाँ जी सर।
लगता है इट्स गुड। नाउ एनी क्वेश्चन, अदर एनी क्वेश्चन, इसमें कहीं इवैल्यूएशन का कहीं कुछ क्वेश्चन है, एनी
नो
सजेशन?
सर, नॉट फ्रॉम माय साइड।
ओके, अदर स्टूडेंट को उसके साइड से?
आई डोंट थिंक सर, नहीं तो वो बोल देते अब तक।
चलो फिर तो नेक्स्ट क्लास
तो मंडे को कर लेंगे।
मंडे, टुडे इज
वही
14
सर,
ना?
3:30 इवनिंग में सर, 3:30।
3:30 ना?
हाँ जी सर।
ठीक है, ठीक है, 14 का 3:30 रखते हैं।
ठीक है सर। ओके सर।
ओके, बाय।
थैंक यू सर।